are Professor Amarjit Mehta and Dr. Sushmita Banerjee. Professor Amarjit Mehta, apart from being the head of department and chief of pediatric nephrology services at SMS Medical College, Jaipur, sir is also Pro Vice Chancellor of Rajasthan University of Health Sciences. And Dr. Sushmita Banerjee, the pediatric consultant and nephrologist at CMRI Hospital, Kolkata. Over to you, sir and ma'am.
Dr. Amarjit, do you want to start?
Good evening. Yeah, ma'am, you can also start. You may start, please.
Okay. So welcome to everyone, the panelists and the audience. I think this is a very important topic today, acute kidney injury. It is something that we need to all be aware of. The risk of this condition exists in all children who are acutely ill. And we look forward to this presentation initially by Dr. Jitendra Meena, who is Assistant Professor, AIIMS, New Delhi. He will talk about the background. And then we have Professor Manish Kumar, who will give us a few case scenarios and then discuss how these cases might be best handled. So let us start, Dr. Jitendra.
Thank you, ma'am. So I'll be briefly talking about the diagnosis and management of childhood acute kidney injury. So AKI is the newer term. Previously, it used to be acute renal failure. So this the AKI has replaced the acute renal failure term because it denotes more of continuum rather than all or none kidney functions. So presently, we define AKI by deterioration of kidney function, which result in the accumulation of nitrogenous waste and inability of kidneys to maintain electrolyte and fluid homeostasis in the body. So why is important to be aware about the acute kidney injury and its management, because it's one of the commonest organ injury you encounter in pediatric population, especially in hospitalized patients. So almost every fourth of the hospitalized patient you see around in your ward and intensive, probably more common in intensive care unit, might be affected with acute kidney injury. So that's why, and its incidence does vary across the globe, but and India does come around, in the one of the countries where AKI is pretty common, especially in critically ill children. Apart from being common, it also increases risk of mortality. So almost 5.4 times higher odds of mortality patients affected with AKI compared to those who are not affected with acute kidney injury. And the risk of mortality does increase with the severity of AKI. In fact, this risk is almost, every third of patients who is receiving dialysis because of acute kidney injury might, die during hospital stay. So that's why it's important to, know about acute kidney injury. So when we look at the geographical variation, especially in the developing world, like countries, resource limited setting like ours, despite being similar incidence, the mortality rate is almost high compared to developed world like North America. Coming to how do we diagnose and stage acute kidney injury, staging is important because the higher the stage, the higher likelihood risk of adverse outcome. So before 2004, there was no uniform definition of defining acute kidney failure. So from 2000 onwards, there are 3-4 standardized definition of defining acute kidney injury. On the first attempt was in 2004, where we came with researchers came with the rifle criteria. This was modified for pediatric population P-rifle in 2007. And same year, the group of researchers came with the acute kidney injury network criteria, which was different from P-rifle in terms of that is does add the small minute change in the serum creatinine of 0.3 in the definition of acute kidney injury. To harmonize all these definitions, the latest and most commonly used criteria is Kidney Disease Improving Global Outcome Criteria 2012. So this defines acute kidney injury by two ways, one by serum creatinine, other by urine output. So either of these criteria fulfilled, then you can label patient having acute kidney injury. So rise in 0.3 milligram per deciliter within 48 hours or 1.5 times rise within 7 days from the baseline, you can label patient as having acute kidney injury. Similarly, if your urine output is less than 0.5 ml per kg per hour for lasting 6 to 12 hours, so that's stage 1 AKI, and more the severer your impairment of the kidney function in terms of further drop in urine output or further rise in creatinine, you have higher severity of kidney injury. So when we see that acute kidney injury is, the continuum process, so you have normal healthy kidneys, and then there are patients at risk of, developing injury. Then if that risk factors are continued, then you have damage. And if the damage in the kidney continue, then you have at final stage where your glomerular filtration rate continue to decline, and then you develop kidney failure. So the difference between damage and GFR, that the currently most commonly used marker for defining AKI, the urine output and the serum creatinine can detect your kidney injury beyond this line. So if you have to detect kidney injury before this line, when your GFR start declining, you need to use structural injury biomarkers, which I will be discussing in further slides. So that's where your crux lies. If you can identify early, you can probably intervene early. So once your the GFR continue to decline, you have kidney failure, and so beyond 7 days, if your kidney failure or acute kidney injury persists, then this is the term which we use, acute kidney disease. And if this kidney impairment continue beyond 3 months, then you have chronic kidney disease. So chronic kidney disease ultimately can culminate into end-stage kidney disease, or a patient can have mortality. So this is a continuum process. The problem is currently used standard criteria, that is use serum creatinine and urine output. Urine output is obviously always cumbersome in younger kids, especially in infants. So it may not be reliable unless you catheterize the patient, and obviously you don't want to catheterize each and every patient hospitalized. The problem with serum creatinine, that there might be alteration in the serum creatinine levels, which are not because of kidney injury. So you can have change in serum creatinine because of fluid overload. If you take excessive protein intake, that might change your serum creatinine. And the major problem is serum creatinine, which we saw in last figure, that doesn't detect your kidney injury unless you have this stage. So serum creatinine is a late marker which rise late in from time of onset of kidney injury. So that's why people would come up with the biomarkers or markers which detect kidney injury early. Based on these, there are 4 subtypes of acute kidney injury can be defined. So when you have normal GFR and there is no damage, so you don't have any injury to kidney. Once you have decline in GFR but there is no damage, so this is the stage which is functional AKI, which is corresponding to most commonly used term, which now should not be used, is pre-renal AKI. So you have functional AKI. So here only there is a adaptive drop on GFR because there is a volume depletion or there is hypotension. So there is a subclinical type where you have normal glomerular filtration rate, but there is a damage to tubular integrity. So this you can be detecting by the structural injury biomarkers. So considering this fact, the Acute Dialysis Quality Initiative ADOQI came up with this latest definition, which is chiefly applied for adult population. So apart from this urine output and creatinine criteria, they do add the biomarkers. So if you have with these category of this label of A and B, which is B kind of denotes that there is a positive structural injury biomarkers as well. So when we talk about the biomarkers in acute kidney injury, so these are basically any protein molecules which can help you in identifying and diagnosing the kidney injury in a way that they can be providing a clue of the injury to glomerular, that is chiefly are the functional biomarkers are serum creatinine and cystatin C. They might be arising from injury to proximal tibule or distal tibule. So depending on which site of tubular injury, there you can have different biomarkers. Commonly studied or investigated biomarkers in pediatric population are neutrophil gelatin associated lipokylin algan, KIM1, LFAB, and then you have TIM2 and IgBF-P7, which is been approved by FDA for adult population early diagnosis of acute kidney injury. Another important point about the biomarkers that their peak might be different for different biomarkers. Like for urine KIM1, you have late rise. Plasma NGAL may rise, within 6 hours, but your urine GAL NGAL peak is at, maybe at 18 to 24 hours. So in this meta-analysis, our group looked at the overall diagnostic performance of these biomarkers in early detection of kidney injury. So looking at this table, the AU diagnostic accuracy, we chiefly looked at the pooled AUC curve of these. And looking at overall, their AUC would vary from 0.7 to, at best of 0.82. So excellent diagnostic accuracy we take when AUC is more than 0.9. So none of these biomarkers, are excellent, but they do have moderate to good diagnostic accuracy in early detection of kidney injury. And again, at different time point, their accuracy do vary. Like your KIM1 have late, around 12 hours the best diagnostic accuracy, where your urine NGAL the best accuracy around 2 to 6 hours. So at different time points from the onset of kidney injury, you may need to use different biomarkers. But the problem with the currently available structural injury biomarkers that there is, only moderate diagnostic accuracy, and unfortunately, unlike serum creatinine, where we do have some uniform defining cutoff of what is being abnormal, we don't have a standardized uniform cutoff of these biomarkers. And the resource limited setting like ours, they are not as easily available as we have serum creatinine that are disposable. And there is obviously doubt about their cost effectiveness, that how effective they are in improving the overall outcome. Considering the limited diagnostic accuracy of these biomarkers, the group of investigators came with the concept of renal angina index, which is akin to the angina pectoris. So unfortunately, like similar to your myocardial injury, where you do have chest pain providing you some clue, the kidney injury, we don't have any symptom like that. So the group of investigators came with this idea that we need to have some a score which can provide us clue that this patient is likely to higher risk of developing acute kidney injury. So this renal angina score is calculated by multiplying the risk strata and NG strata. So risk strata include your intensive care admission, stem cell transplantation requirement for mechanical ventilation, and inotropes. So this score can be 1 to vary from 1 to 40. If you have a score of more than 8, so this renal angina index score need to be performed within 12 hours of hospital intensive care admission. So if you have a renal angina index of more than 8, this does provide a clue that this patient has a likely higher likelihood risk of developing severe AK on day 3 of hospital stay. So in this systematic review, we looked at that, you perform renal angina index on day 0, and if you score more than 80, more than 8, the probability of being developing severe AKI on day 3 is around 40%. With this renal angina index, if you can add the urinary NGAL, this probability positive predictive value can increase 55% by adding the urinary NGAL. So a combination of renal angina index and biomarker seems to be that predicting better that which patient at higher risk of developing severe AKI. In the armamentarium of this risk stratification tools, the latest one is we have furosemide distress test. So this furosemide distress test assesses the integrity of tubule. To have diuresis induced by furosemide, your tubules need to be integrated. So there are multiple steps that your furosemide need to be transported from pericapillary tubule to proximal tubules. Then it need to act on NKCC channel on this ascending loop of inlay, and then finally diuresis. So basic concept of furosemide stress test that after administering of furosemide around 1 to 1.5 milligram per kg in a patient who is adequately resuscitated in terms of intravascular volume. So this patient should not be dehydrated or in shock, and the patient should have persistent oliguria. So after administering the intravenous furosemide, if your urine output, chiefly the data is available from adult population. So there, if you have more than 200 ml urine output over next 2 hours, this suggests that the tubules are still intact. There is no significant tubular damage. So for these patients, you can further administer urine intravenous fluid to maintain their intravascular volume and to maintain urine output. And here urine output can be reliably used to assess the organ perfusion. But if it fails, then there's no point of giving further fluid, because you are likely to result in fluid overload and further detrimental patients. So this is, as I told you, chiefly adult data. Recently, from our center, we do have some data which suggests that urine output of more than 2 ml per kg per hour is kind of predict an excellent requirement of dialysis and developing of stage 3 AKI with AUC of 0.92 for prediction of stage 3 AKI and 0.96 for requirement of dialysis. So based on the current evidence, if you need to identify a patient at high risk of developing severe AKI, after admission to intensive care unit, you need to assess renal angina index. If it's positive, then look at the biomarkers. If your biomarkers are considerably high, you may consider furosemide stress test, and if it failed, then this might be an indication, or at least this is the time point where you should start intervening, at least preventive measures. And if you're already developing fluid overload, you might need even consider kidney support therapy in terms of hemodialysis or peritoneal dialysis, whatever is feasible. We do encounter significantly nephrotoxic associated AKI. So this is one program Ninja, where if you carefully observe the nephrotoxic drugs and you have e-alert system in your hospital for detecting rise in the serum creatinine, and if you actively look for, you can reduce the incidence of AKI. So in fact, investigators have showed that in pediatric as well as neonatal intensive care unit, by carefully looking at these rise in creatinine and exposure to nephrotoxic drugs, you can reduce the incidence of rate of AKI over that time point. So coming to the etiology, acute kidney injury etiologies are traditionally being classified into 3 different categories. The most simplest is the post-renal causes, where you have obstruction downstream the kidney parenchyma. The most tricky situations are where you have decreased kidney perfusion. So you might have blood loss or fluid loss leading to impairment of the intravascular volume. So in this stage, you might have the functional adaptive drop in GFR. So in real sense, there is no intrinsic injury to kidneys, but your GFR might already be in drop. But the same etiology persists at some point of time. You may these all etiologies can lead to intrinsic kidney failure or acute tubular necrosis. So coming to the intrinsic causes, you may have injury to glomeruli in terms of acute glomerulonephritis secondary to post-infectious GA and IgA nephropathy and other immune complex mediated glomerular injury. Then you can have vascular etiology like hemolytic uremic syndrome, severe malignant hypertension. Then there might be injury through tubules by various nephrotoxins like rhabdomyolysis, hemolysis, and prolonged ischemia. Then there are a number of tropical infections which can lead to kidney injury. So when we look at the what proportion of patient, these factors contribute to overall acute kidney injury across the globe. So diarrhea and dehydration are probably the most common cause in our part of world. So this row would, that's where we lie. That dehydration is probably the most common cause, and hypotension shocks followed that. But we need to keep in mind that acute kidney injury, especially in hospital settings, are most of the time multifactorial. So it's sometimes difficult to pinpoint a single etiology. So you may have multiple factors contributing to acute kidney injury, especially in intensive care setting where patient might be exposed to hypotension, sepsis, nephrotoxic drugs. So yeah. So approach to a patient with suspected AKI chiefly depend on you need to remember the causes and then you evaluate accordingly. So in history, obviously, as most common cause is the fluid loss in our part of world. So you need to ask history of vomiting, diarrhea, blood loss, and tropical infections are again common. So you need to look for fevers. Then edema, hematuria, pallor, icterus these are chiefly to look for the underlying cause of glomerular nephritis as the underlying cause of acute kidney injury. Then there might be the recurrent urinary tract infection and voiding dysfunction, pinpointing to the obstruction downstream in the lower urinary tract. Simultaneously, you need to also look at the history of complications of acute kidney injury. So you might have fluid overload leading to fast breathing dyspnea. You might have severe hypertension and uremic encephalopathy. So ask for seizure, ultrasensorium. In the examination, chiefly you need to focus at the detecting the complications. So you might have hypertension, you might have blood loss leading to anemia, or hemolytic uremic syndrome might be an underlying cause of anemia in a patient with acute kidney injury. Then you need look for evidence of fluid overload in terms of crepitation, edema, S3 ghrelin. The first line investigation, a patient with suspected diagnosed acute kidney injury should be to look at the serum creatinine, which would not only confirm your diagnosis of AKI, but also provide you with the severity of AKI. Then the urea, blood pH, electrolytes are chiefly to look at the complication of the acute kidney injury. The complete blood count may provide you the underlying clue to etiology of acute kidney injury. Then again, urine analysis is the key component of initial investigation of patient with suspected acute kidney injury. So if you have proteinuria and hematuria, might think of that this underlying cause might be glomerular injury. And ultrasound KUB again a crucial component of initial investigation because it does provide you clue if there is a downstream obstruction. Coming to the further investigation would chiefly determine based on the initial history examination and initial investigation. So if there is a clue of underlying cause of acute GN, then you would further proceed with the various serology and complement C3 levels. If you have initial investigation and history, you find that there is a clue to anemia and severe hypertension and thrombocytopenia, might think underlying cause of HUS and TTP, and then you will look at the cystocyte in peripheral HPR and other further investigations. Coming to the complications, so acute kidney injury when it's severe can affect any organ system. So apart from dyselectrolytemia and metabolic acidosis, it can lead to encephalopathy. It can affect your lungs with fluid overload and further inflammatory changes in ARDS. It can affect virtually any organ system. Now we'll briefly talk about the principles of management of pediatric AKI. So the overall conceptual framework that patient at risk of AKI, you continuously and closely monitor their urine output and serum creatinine. So wherever you suspect that there is acute kidney injury, you will investigate the underlying etiology that I briefly touched upon in the last two slides. If there is stage 1 AKI, you will start in a preventive measure. So these are chiefly adjusting your drug dosage, avoiding nephrotoxic drugs, avoiding too much of extra fluid and carefully looking at the fluid balance. So this is a slide again, showing the same thing, that beyond, stage 1 AKI, you will start looking carefully and adjusting your drugs and fluids. Even at stage 2 AKI and stage 3 AKI, you might consider starting the kidney supportive therapy. One of the crucial, dilemma in patient with acute kidney injury, that how to go about fluid management. So optimizing the intravascular volume is, very crucial. You need to maintain a euvolemia, because both intravascular volume depletion and fluid overload are detrimental to kidney health as well as overall health of the patient. So you need to maintain somehow, the euvolemia. So in a patient who doesn't have any fluid overload or volume depletion, the ideal fluid replacement would be around 400 ml per meter square plus ongoing losses, which is chiefly urine output. And this fluid need to be given preferably, per oral. One would want to avoid giving intravenous fluid unnecessary. But if you have baseline some volume depletion, or there is already fluid overloaded, so you would want to, have some weight reduction over the period. So you might not, give exactly this much amount of fluid. You might need to give less amount of fluid. So overall, you would want a weight loss of around 0.5 to around maybe 1% of weight loss every day. So accordingly, you need to manage your fluid administration, which is preferably should be oral route. Then coming to management of the complications, so you can have pulmonary edema, fluid overload, which need to be managed by either intravenous fluid furosemide, and if it's not controlled with that, then you might need dialysis, oxygen therapy, and fluid restriction. If there is hypertensive emergency, you may use intravenous labetalol and nitroprusside infusion. Then there are various anti-hyperkalemic measures, which I'm sure most of you are aware of. Then drug dose adjustment is required in most of the patient with acute kidney injury. So two kinds of drugs are chiefly to modified. One is, nephrotoxic drugs, because they might deteriorate your kidney function further. And there are other group of drugs which are chiefly excreted through the kidneys. So their dose might need to be adjusted. So most of the patient would require drug dose adjustment once your GFR drops below 50. If you have, facility available for monitoring drug labels, then is, drug doses need to be modified accordingly. The one thing which, at the postgraduate level, you should be aware of, and you should be, following in your routine clinical practice regularly, that you should avoid using a combination of nephrotoxic drugs like ACE inhibitors and NSAIDs. And there are antibiotics which, when used simultaneously, has been shown to report it to higher risk of acute kidney injury, like piperacillin tazobactam plus vancomycin combination. So this kind of combination ideally should be avoided whenever possible. In terms of pharmacotherapy for acute kidney injury, unfortunately, we don't have any drugs as of now to manage acute kidney injury, or in fact in helping in the recovering the kidney injury. The only drug which is probably currently, effective in some bit of reducing the risk as a prophylactic measure is aminophylline in patient with neonates with birth asphyxia, which may reduce the overall risk of acute kidney injury. Nutrition is again, the most probably the ignored part in the management of a patient with acute kidney injury, but probably is the only, intervention which can help in recovering the abuse from acute tubular necrosis. So ideally, these patients should be, given oral feeds initially to begin with, the calorie target around 60 to 70 kilocalorie per kg per day, with protein around 1 gram per kg per day. It can be increased later on. Coming to the management of specific causes of acute kidney injury. So if you have acute tubular necrosis, you need to again, avoid nephrotoxic drugs, optimize the intravascular volume. If you have glomerulonephritis, you might consider giving immunosuppressive therapy after finally pinpointing and establishing diagnosis on kidney biopsy. Hemolytic uremic syndrome might require plasma exchange and other immunosuppressive therapy. So does patients with ANCA-associated vasculitis. If there is obstruction downstream, you might need surgical intervention. Kidney replacement therapy I won't be touching upon because next webinar will be dealing with the kidney support therapy. Probably last few slides and from my side that acute kidney injury, not an one-time insult. So patients do have long-term complications. So it depends on severity of acute kidney injury. So in this tree, the hanging kind of are representing the nephrons. If you have more severe nephron numbers, the regenerated nephron numbers are pretty less. So in the severe AKI, where most of the nephrons are injured, you have more fibrosis, and ultimately you are left with very less number of nephrons, and they do have long-term complications. In terms of so apart from short-term complication, that AKI does increases risk of mortality, length of hospital stay, and greater mechanical ventilation requirement. The long-term complications are proteinuria, hypertension, and chronic kidney disease. So once you develop a patient with acute kidney injury, some proportion of patient might recover completely, but many patients might develop from AKI to something called acute kidney disease following that chronic kidney disease. And some patient might not even recover at all. They would directly progress to end-stage renal disease. So overall, AKI is not a single-time insult. So looking at this figure, the insult from the long-term consequences of AKI does depend on the the baseline nephron number, so which is the nephron endowment. So if you have acute kidney injury at very young age, the long-term overall lifespan that might not be affected much. But if you have AKI at older age and is more severe AKI, and if your baseline nephron numbers are very less, then you might have very severe consequences, which is represented with this line. So that's why it's important to monitor the patients who survive acute kidney injury in hospital setting. They need to be followed up regularly, especially for monitoring for proteinuria, hypertension, and serum creatinine to look for development of chronic kidney disease. So first, initially, you might rapidly, would want them at least at 1 to 3 months regularly, initial 1 year, then later on maybe 1 to twice per year. So to conclude, currently we use serum creatinine and urine output, and ideally speaking, both should be used because their combination provide better probability of recognizing kidney injury early. Early prediction is important because, as I showed you, the more severe the kidney injury, higher risk of mortality as well as higher risk of the developing long-term complications. So if you identify early and start preventive measures, you might prevent progression of acute kidney injury to severe stage. As such, unfortunately, we don't have any drugs to treat acute kidney at present. And as I showed, that acute kidney injury is no longer considered as one-time insult. It does have long-term consequences. So with that, I'll finish my talk.
Thank you, Jitendra. That was a really nice update of AKI. I think despite all that is happening, all these exciting articles and reviews about how to pick up AKI early, the biomarkers, renal angina index, despite everything, at the end of the day, clinically, we are left with the knowledge that AKI does cause, severe AKI particularly is associated with poorer outcomes. And therefore, it is really essential to try and prevent this occurring. And therefore, the early recognition, knowing what the risk factors are, managing hypovolemia very early, managing hypertension early, but at the same time preventing fluid overload, avoiding nephrotoxins, all these issues, I think you've covered it excellently. There are quite a few questions in the chat box, but I think we'll take them at the end.
Yes, ma'am. So we'll.
So
I'll
I
try
look-
to answer meanwhile some of these questions in chat box. So Dr. Manish, you can begin with that.
Maybe Dr. Amarjit could introduce Dr. Manish quickly, and then we can carry on. Dr. Amarjit, are you here? Dr. Manish, you could begin sharing.
Am I audible?
Yes, you are. Yes.
Yeah. Good evening again. And first of all, thank you, Dr. Jitendra. It was a very lucid talk and very interesting talk, and all new things about AKI were included. And now we are going to case scenarios. And it is my proud privilege to introduce my friend, Dr. Manish Kumar. He's a professor in Department of Pediatrics at Chacha Nehru Bal Chikitsalaya, Delhi, which is an autonomous institute under government of NCT of Delhi, and it is affiliated with GGSIP University, Delhi. So, Dr. Manish, the field is all yours.
Thank you, sir. Thank you for your nice words. So I will start with some case scenarios on AKI. So Jitendra has specifically asked me not to cover HUS and cases related to glomerulonephritis because these cases will be covered separately. So to start with, our first case is a 7-year-old boy with normal weight and height who came to emergency with history of fever, loose stool and vomiting for 1 day. And the mother gave history categorically that the child had not passed urine since last 12 hours. So on examination, the child was drowsy and eyes were sunken, the skin color were markedly reduced. There were cold extremities, the pulses were feeble, there was mild tachycardia, and the blood pressure was 80 millimeter of mercury, and that by systolic BP, by oscillatory method. So as the child was in shock, the child received normal saline bolus, 300 ml over 30 minutes. The BP normalized to some extent. It became 90/60. And after that, the child was managed as per WHO guideline for management of severe dehydration. And he received 1500 ml of ringer lactate over the next 3 hours. So on investigation, the child had hemoglobin of 13.8. The counts were slightly raised with neutrophilic leukocytosis. The platelets were normal, but blood urea and creatinine were markedly increased. Urea was 104 and creatinine was 4.1 milligram per deciliter. Uric acid was also high. There was hyponatremia and hypokalemia, and the blood gas analysis showed metabolic acidosis. So as the urea creatinine was very high, we specifically asked for any history of nephrotoxic drug exposure, but there was no history of any drug intake. And over the next 6 hours, the urine output was 100 ml. The signs of dehydration improved with ringer lactate, and after the child was continued with maintenance IV fluid. Over the time, the pulse rate decreased, there was no vomiting, and the oral acceptance also improved. So we kept a provisional diagnosis of acute diarrhea with severe dehydration with shock with AKI stage 3, as the urea creatinine was very high. Normally in diarrhea dehydration, we do see creatinine up to 1.4, 1.5 like that. But 4.1 was very high for this child. Though history was acute, we kept a provisional diagnosis of AKI secondary to diarrheal dehydration with underlying CKD. So next day, the urine output improved. The child passed 300 ml in last 24 hours. That amounted to 0.7 ml per kg per hour. There was no dehydration. BP also normalized, but we continued with IV fluid and ORS. So investigation revealed urea creatinine normalizing to some extent. So not normal, but in a decreasing trend. Create became 3.7, but it was still very high. Sodium potassium became normal. And we did a USG KOB as we thought it could be a CKD that showed a normal sized kidney with increased ecotexture and the maintained corticomedullary differentiation. So on third day, urine output further improved. We stopped IV fluid. Creatinine decreased further to 3.3, or it was like the day before, 3.4. And at this time, we decided to do a urine electrolyte just to calculate the fractional excretion of sodium to see whether it's the functional AKI, prerenal AKI, or the child had developed ATN. So creatinine level was very high. So probably the child had developed ATN. But again, we just did a fractional excretion of sodium and it came out to be 2.2%. That goes in favor of acute tubular necrosis. Now, urine sodium was also high. It was 70 millicolon per liter. On day 4, the urine output improved further and the creatinine became 1.3. That means definitely the creatinine was coming down from somewhere around 4 to 1.3. Electrolytes were normal. So we decided to discharge the child with a diagnosis of AKI secondary to hypovolemia and with advice to follow up at 2 weeks. Just we wanted to see whether the child had persistent AKI, or just the follow-up was planned to see if the child develops CKD in the long run. So the child is yet to come. The child is discharged 3 or 4 days ago. So this diarrheal AKI mainly results from decreased renal perfusion and glomerular filtration due to hypovolemia. So because of diarrhea, there is a loss of extracellular fluid volume and there is a decreased renal perfusion that reduces the glomerular filtration. And if the AKI reverses over the next 1 to 3 days with restoration of extracellular fluid volume, there is mainly functional AKI, or we earlier used to say is a prerenal AKI. But if the hypovolemia is sustained or is severe, that might lead to acute tubular necrosis. That what could have happened in this child. So in most of the cases, the prognosis is relatively good with a majority of children that recover over the time. But again, long-term follow-up is required because of the risk of CKD is high in those cases with ATN or where the AKI is persistent beyond 7 days. So in a study from our center, we tried to find out the etiology and outcome of community-acquired AKI in patients who were hospitalized. The diarrhea and dehydration was the most common cause of AKI. The 40% of children, out of 215 children we saw over a period of 1 year, the 40% of children had AKI because of diarrhea and dehydration. And the next common cause was sepsis that accounted around 1/4 of cases of all AKI. The rest of the AKI were because of tropical febrile illnesses or primary renal disease. So our second case is an 11-year-old boy with a normal weight and who had a history of fever for 1 to 2 days, 15 days ago, swelling all over body for 5 to 6 days, decreased urine output for 2 days. There was no history of rash or red colored urine. On examination, child was pale. There was no icterus. The edema was present. BP was normal, but there was a hepatomegaly, liver of 5 centimeter, and spleen was also palpable 2 centimeter below subcostal margin. So investigation revealed an anemia, hemoglobin of 8. Counts were slightly raised, 19,200, and the platelets were markedly reduced to 39,000 at the time of admission. Urea was 67, creatinine was 3.5, but uric acid was very high, it was 38. Sodium was low, 128 of sodium, and there was a hyperkalemia. Calcium phosphorus was normal, calcium with a value of 9.4, phosphorus was slightly on the lower side, it was 3.6. SGOT, SGPT were slightly raised, and the serum albumin was 3 gram per deciliter. LDH was also markedly high, it was close to 16,000. So routine microscopy examination revealed a 1+ proteinuria. There were no RBCs or cast on microscopy examination. So differential diagnosis was kept as complicated malaria with acute kidney injury, possibility of hemolytic uremic syndrome, or some tropical illness like rickettsia or leptospirosis with AKI. Because there was anemia, thrombocytopenia, high LDH. So on the second day of illness, the urine output decreased. It came down to around 0.5 ml per kg per hour. The edema increased. The child developed respiratory distress. So we planned for a hemodialysis. So next day, the blood examination revealed further fall in hemoglobin. It became 5.9. The counts were high, 21,400. Platelets reduced further. Reticulocyte count was 1%. But the peripheral smear didn't show any evidence of cystocytes or hemolysis. So urea creatinine was in the similar range, around 74 of urea, create of 2.3. Uric acid was same 30, LDH in the range of 16,500. Though peripheral smear was negative for malarial parasite, no evidence of hemolysis, there were presence of blast. And we specifically asked the pathologist to see carefully because the counts were not that high. So we didn't think initially that it could be leukemia, though there was anemia, thrombocytopenia, hyperosmomegaly. But in the first go, the pathologist didn't report of blast. But when we specifically asked, can they see any blast, then they reported that yes, there were presence of the blasts were present in the peripheral smear. So we kept a diagnosis of acute leukemia with tumor lysis syndrome with acute kidney injury because the uric acid was very high. It was more than 30, 38 like that. Though the other features of tumor lysis syndrome was not present, like there was no hyperphosphatemia, no hypocalcemia, but definitely the uric acid was very high. So we started managing child on the line of tumor lysis syndrome. We gave plenty of fluids in the range of 2 to 3 liters per meter square per day. The hemodialysis was done on daily basis. Sodium bicarbonate was added in the IV fluid for urine alkalization. Raspberry cage was started, which converts the uric acid to the more soluble allantoin, and allopurinol was added, which is a xanthine oxidase inhibitor. So over the next period of next 2 days, the hemoglobin improved. We gave packed cell transfusion. The hemoglobin became 9.8. The platelets remained low. Urea creatinine, because of dialysis, it came down. Creatinine became 1.9 and 1.5. And uric acid also decreased from 38 to 18 on day 5. LDH also starts showing declining trend. The calcium phosphorus remained normal, even though phosphorus was on the lower side. So a bone marrow was done, and the finally diagnosis of Burkitt lymphoma was made. And so it was a case of Burkitt lymphoma with tumor lysis syndrome with AKI. So tumor lysis syndrome is an oncological emergency, and it may result in hyperuricemia, hyperkalemia, hyperphosphatemia, and hypocalcemia. So most of the cases, TLS develops after start of chemotherapy, but in some cases it may present spontaneously even before starting of chemotherapy. So very high level of phosphate may lead to precipitation of calcium phosphate crystals in the tubules and may lead to AKI. So adequate hydration and alkalization of urine are the mainstay of treatment, and hemodialysis is indicated in cases of severe hyperuricemia like our case, or hyperphosphatemia with oliguria. So this flow diagram just will help you to understand the pathogenesis of tumor lysis syndrome. So either with the chemotherapy drugs or spontaneously, the tumor cells may lyse and release purines, xanthines, which gets converted to uric acid by xanthine oxidase, or the phosphorus can lead to calcium phosphate precipitation in the tubules. Xanthines may result in xanthine crystals. Uric acid can result in uric acid crystals, and all these crystals can deposit in the tubules and lead to acute renal failure. So allopurinol acts here. It inhibits xanthine oxidase and prevents the formation of uric acid from xanthines. But again, there is a accumulation of xanthines which may lead to formation of xanthine crystals and acute renal failure. So it's not very much effective. But raspberry case acts here. So it converts the uric acid crystals to allantoin, which is more water soluble and can be excreted easily. So acute renal failure in leukemia or lymphoma may occur due to direct infiltration of renal parenchyma by malignant cells, or rapid tumor lysis, just explained in this flow diagram, or compression of the renal tubules by the tumor. So our case 3 is a 9-year-old male, weight 22 kg, had a history of fever for 3 days, erythematous rash over both the upper and lower limbs for last 3 days, and pain abdomen and vomiting for 2 days. So this rash was very typical of dengue. So the provisional diagnosis of severe dengue was kept based on the clinical findings. The child was febrile at the time of admission. There was tachycardia. So blood pressure was on the lower side, so 90/76 with narrow pulse pressure. Fatigue were present over both the lower limbs. The extremities were cold, and the liver was 4 centimeters, and it was tender hepatomegaly. The spleen was not palpable, and on examination, chest examination, there were equal bilateral equal air entry. So investigation revealed increased hematocrit, the 50%. There's a leukopenia, thrombocytopenia, and urea creatinine was on the slightly on the higher side. For this age, 0.6 of creatinine is definitely higher. And the LFT revealed a mild increase in SGOT, SGPT, and dengue NS1 antigen turned out to be positive. The child tested negative for malaria on the peripheral smear and rapid malaria antigen test. So as the extremities were cold and some features of shock was there at the time of presentation, the child received a bolus of fluid of 10 ml per kg over 30 minutes. And there was slight improvement in blood pressure. It became 96/70. And this bolus fluid was followed by a ringer lactate infusion with a rate of 7 ml per kg per hour. After 6 hours, the hematocrit was repeated. Hematocrit and platelets counts were repeated. There was slight decrease in hematocrit from 50% to 80%. The platelets remained similar in the center range around 48,000. The child did pass some urine. So there was 0.6 ml per kg per hour of urine output over the next 6 hours. So as hematocrit was still high, so the fluid was continuing the same rate, 7 ml per kg per hour over next 16 to 18 hours. So probably we're dealing a child with severe dengue with AKI. So next day, next 24 hours, the urine output decreased and it was 0.5 ml per kg per hour. So over last 24 hours, if we calculated the total fluid intake and it was 3850 ml, the child had a weight gain of 2.5 kg. The BP was still on the lower side. The hematocrit was still high. There was thrombocytopenia. And we noticed a rise in urea and creatinine. Creatinine became 1.2. So from 0.6, the creatinine became 1.2. It was almost 100% rise in serum creatinine from the baseline. If we take 0.6 as a baseline of serum creatinine, baseline value of serum creatinine. So there was a respiratory distress, some difficulty in breathing. So X-ray chest was done, and that showed a bilateral moderate pleural effusion. Ultrasound abdomen showed a moderate ascites. So all these features are suggestive that the child had a plasma leakage, and it was a severe form of dengue with AKI. So fluid was reduced to some extent. It was made 5 ml per kg per hour after 24 hours, and inotropes were added in view of persistent hypotension. So on day 3 to day 4, the child weight was 25 kg, so almost 3 kg weight gain from the time of admission. The urine output decreased further. It became 0.5 ml per kg per hour against a total fluid intake of 2.4 liter. The BP was maintained on the range of 96/60 with the help of inotropes, but there was further increase in respiratory distress because of fluid overload. Hematocrit was still high, 44%, but definitely lower than what it was presented at the baseline at the time of admission. Creatinine increased further to 1.8 milligram per deciliter. The electrolytes were normal and blood gas showed a bicarbonate of 12. So we are dealing with severe dengue with AKI stage 3. So as there was a decreased urine output, there was increasing evidence of fluid overload. The fluid was restricted on the line of the AKI regime. So it was made 400 ml per meter square per 24 hours, plus replacement for losses like urine output. So the question is, does this child require a renal replacement therapy? So for that, we calculated the percentage fluid overload, and it came out to be 25%. So percentage fluid overload can be calculated by either of these formula, where the fluid in liters intake minus fluid output divided by weight at the time of admission. So the fluid overload more than 20% is associated with increased mortality. It also delays the diagnosis of AKI as serum creatinine becomes diluted in the extravascular compartment because of fluid overload. It fails to detect AKI timely because serum creatinine fails to rise. So literature says that the need of dialysis should be considered if there is a fluid overload of more than 10%. So what should be the choice of dialytic modality in this child? So as the child has hypotension, there is no hemodynamic stability. So hemodialysis should not be preferable in this child. PD will not be very helpful because the child is in shock. So the best modality of dialytic modality will be CRRT in this case if there is a facility, if the facility is available at the center. So coming to the last case, a 6-year-old child came with history of fever, headache, vomiting for 1 day, the bluish discoloration over the limbs. So on examination in the emergency, the child was drowsy, the extremities were cold, there were multiple ecchymotic patches over both the lower limbs and upper limbs. And there was tachycardia, mild tachypnea, the BP was 60 millimeter mercury. So normal saline boluses were given as the child was in shock. So initial bolus was given with 15 to 20 ml per kg over 20 minutes. As the BP failed to rise, so further 2 more boluses were given with 350 ml each over a period of 1 hour. So a total of 1000 ml of normal saline were given over 1 hour just to as a treatment of shock. But the BP failed to rise, so dopamine infusion was started in the emergency itself. So blood sample was taken for blood counts, kidney function test, electrolytes, blood gas, blood culture sample was taken, coagulation markers, sample for coagulation markers were taken also. The first dose of injection ceftriaxone was given in the emergency. Child was intubated and shifted to PICU. So provisional diagnosis of sepsis with shock was made probably meningococcemia because short history, fever of 1 day and the rash. So probably it could be meningococcemia presenting with shock. So investigation revealed a normal hemoglobin. The counts were raised with neutrophilic predominance, and the platelet counts were also reduced. Blood gas showed metabolic acidosis. PT-INR was deranged. APTT was also increased. The child had deranged KFT with urea of 56 and creatinine of 1.1. There was hyponatremia and potassium level were high. So in ICU, the BP varied between 90 to 100 by 50 millimeter of mercury. So child received intermittent fluid boluses for low blood pressure episodes, totaling about 500 ml of additional normal saline in last 24 hours. The child was also continued with maintenance IV fluid. Meantime, the child received a lot of fluids. So for the management of shock part, the adenine infusion were also started. As the coagulation parameters were deranged, the child received 300 ml of fresh frozen plasma. So on day 2, there was increasing edema. The purpura got worsened. The child gained 2 kg of weight. Urine output was 800 ml in last 24 hours. That was around 0.4, 0.5 ml per kg per hour. The blood pressure remained stable in the range of 100 by 50 with the help of 2 inotropes, dopamine and adrenaline with intermittent normal saline boluses. Creatinine became increased further to 1.8 milligram per deciliter. And meantime, we got the blood culture report which showed the presence of Neisseria meningitis. So it was a case of meningococcal shock. So with time, the oxygenation became more difficult. The chest X-ray shows diffuse hazy markings consistent with pulmonary edema. So total fluid intake was close to 3 liter against output of only 800 ml. So fluid overload was calculated and it came out to be 11%. So the plan of therapy was to restrict fluid intake. The need of dialysis should be considered because there was a rising creatinine, decreased urine output, and also there was evidence of fluid overload. Again, the choice of dialytic modality depends on the facility available at the center. So few words about the sepsis-associated AKI. The sepsis-associated AKI is a life-threatening complication in critically ill children, and up to 2/3 of patients with septic shock develop AKI. And in half of them, AKI develops even before presenting to emergency department. So the most of the cases of sepsis, septic shock, who present to the emergency are already in AKI at the time of presentation. There is a high risk of mortality, there is a higher need of KRT, and a higher risk of progression to CKD in these children. So coming to the pathophysiology of sepsis-associated AKI, so earlier it was thought that sepsis may result in hyperperfusion of the kidneys and that can lead to acute tubular necrosis. But it has been seen that it's not only hyperperfusion of the kidney that results or ATN that results in AKI and sepsis. There is an interplay of microcirculatory dysfunction, dysregulated inflammatory response, and cellular metabolic reprogramming that can lead to AKI, and that can be better understood by this diagram. And here we can say there is a this circulatory dysfunction, or because the dilatation of the constriction of the afferent arteriole and the dilatation of the efferent arteriole, that results in the decreased glomerular filtration pressure and the decreased GFR. So another aspect in sepsis AKI is this. These are the PAMs or DAMs. That is the pathogen-associated molecular patterns and damage-associated molecular patterns that gets attached to the these toll-like receptors on the tubular epithelial cells, and these lead to further damages by releasing reactive oxygen species and oxidative stresses. So another aspect is the endothelial dysfunction, and that results in the adhesion and activation of the leukocytes, aggregation, and there is a sluggishness or the slowing of the blood flow, and also that increases the vascular permeability. So all these factors can lead to acute tubular necrosis or ATN or AKI in children with sepsis. Now coming to the treatment of septic shock or the prevention of sepsis associated AKI. So there should be a protocolized treatment as suggested by the Surviving Sepsis Campaign International Guidelines. The child who presents with septic shock should receive fluid therapy. Bolus fluid should be given up to 40 to 60 ml per kg, with each bolus consisting of 10 to 20 ml per kg. There is a controversy regarding the type of fluid, whether 0.9% normal saline should be used or balanced crystalloid should be used. So evidence is in favor of balanced crystalloids, because use of normal saline as a bolus fluid is associated with hyperchloremic metabolic acidosis, and hyperchloremia can lead to vascular constriction and can result in AKI. So even this Surviving Sepsis Campaign guideline suggests, though there is a weak recommendation, we suggest using balanced buffered crystalloids like ringer lactate rather than 0.9% saline for the initial resuscitation of children with septic shock or other sepsis-associated organ dysfunction, though recommendation is weak and there is very low quality of evidence. So at all costs, the fluid overload should be avoided. So if you are giving fluid boluses, one should keep in mind just to check the evidence of fluid overload, like hepatomegaly or appearance of crepitations. So, and as soon as the child develops evidence of fluid overload, the fluid boluses should be stopped there only, and the child can be started over the vasopressors. So another aspect of this protocolized treatment is the antibiotic treatment should be started within 1 hour if someone suspects that this could be sepsis or septic shock. So vasopressin agents should be started if there is a fluid refractory shock or the child develops evidence of fluid overload. So it could be either epinephrine or norepinephrine with a target map between 5th to 50th percentile or more than 50th percentile for age. Again, kidney replacement therapy, there is a role of kidney replacement therapy if there is an evidence of fluid overload. So the timing of initiation of kidney replacement therapy, so it's not very helpful if the kidney, if the KRT is started early versus late. So to conclude, so diarrheal disease and sepsis are common causes of AKI in hospitalized children. Early diagnosis of septic shock and protocolized fluid therapy may prevent the progression of AKI and need of kidney replacement therapy. Fluids should be used judiciously to avoid fluid overload, which is an important risk factor for AKI and mortality. And dialysis should be planned if there is a fluid overload of more than 10%. And children with partial or complete renal recovery should be followed up for early identification of CKD. So I will end here. Thank you.
Well, thank you, Dr. Manish, for these very good 4 cases, because there are umpteen number of cases and almost every disease and every situation may lead to AKI, but these are 4 important situations which you have described in a very nice way. So I think Dr. Sushmita, are you going to start with comments of other panelists, or are we going to start with the question and answers first?
Can I ask a question to start off? Dr. Jitendra or Dr. Manish, we
Yes,
haven't
ma'am.
really touched much on neonatal AKI in these two talks. But if you look at the evidence, drug therapy of AKI, specific therapy, the only real evidence is in favor of theophylline, caffeine in neonatal AKI as a mode of prevention. There is some evidence for these drugs. Any comments?
Ma'am, I did mention during pharmacotherapy that aminophylline does work in preventing the AKI and setting of birth asphyxia. So there is some, data from clinical trials that a single dose of aminophylline in patient in birth asphyxia setting may prevent progression of acute kidney injury.
And also the fact to make the audience aware that the neonatal criteria for diagnosis of AKI are just a little bit different. What about N-acetylcysteine? What are your comments about this drug?
For N-acetylcysteine, there previously, some data to suggest that in contrast, induced AKI it may be helpful, but the latest, large trials and meta-analysis clearly show that it doesn't work at all. So as of now, as per latest evidence, there is no role of N-acetylcysteine prophylactic therapy and preventing the contrast-induced AKI.
Okay, and there are quite a few questions about fractional excretion of sodium, fractional excretion of urea. Any thoughts about these?
Yes, ma'am. This fractional excretion of sodium, it can help in differentiating pre-renal or functional AKI from ATN, but it's not very useful if the child is on IV fluid or the child has received diuretic. So theoretically, though, if the FeNA is more than 1%, it may indicate ATN. But again, if the child has received IV fluid or diuretics, then it will not be very useful.
So what I've been thinking is that, we are looking at biomarkers, and biomarkers, many of them are indicating a structural injury to the tubules. And when we were looking at FeNA and fractional excretion of urea, that is also what we are looking at. We are looking at patients who have had tubular injury and therefore are unable to reabsorb these substances. And that is why these are abnormal in intrinsic kidney injury. So there is a little bit of a parallel there when we have kind of shifted over to thinking and talking about biomarkers rather than those parameters nowadays, I think. Okay, so